We've all got marks on our body, and we've all got little moles or little craggly bits and things like that. Whereas, like some of our patients like to say they're barnacles. So what we do, we look at them and we make an assessment based on, I suppose, making a really systemic approach and what we think of the lesion. Some of the really common ones that are benign is what we call a seborrheic keratosis, SEBK. Ultimately, for the patient, if it looks like someone's thrown a sultana at you and it's stuck there, that's why I always say, yeah, it's a SEBK. So if it looks like the ones that you could just peel off, they're generally okay. Under my dermatoscope, they almost look like a brain, in the patterns that they've got. They're really well defined, and it's really obvious what that lesion is. And when we look at it under the dermatoscope, it's really obvious. So they're generally fine. A lot of patients don't like them, and we do get more of them as we get older. So the stuff that wasn't in the fine print for being further away from 20. Some of the other things that we see a lot of the time are just the barnacles, which is just scaling of the skin, and most of that's fine. Especially if when you put moisturiser on it, it goes away. So another good reason to use skincare treatments and all that sort of stuff. Age spots, so just those little light brown areas that you may see, that we do see as we get a bit older. They're generally all okay. However, some of the pre-cancer stuff that we may see, solar keratoses. So what that looks like is quite often small. You often see it on the forearms and your hands, and maybe on those prominent areas of your face. It just looks scaling. It's not ulcerated. If it's got an ulcer, then that's more serious. But if it just looks like a little scaling area, that little white scales on it, and you can scratch it off, but it keeps coming back, it's quite often a solar keratoses, and it's just sun damage. I like to let patients know that sometimes that could be considered pre-cancer, if you like, because there's obviously damage to the skin, and cancer is damage that's not controlled. So if you've already got the damage, you only need a few more changes in that, and it can lead to cancer. With that particular one, what it can lead to is squamous cell carcinoma in situ. And it's a little bit more sinister, but if you're going to that's the important time to get it when it's at that stage. So it's not invasive yet. It hasn't formed a defined squamous cell carcinoma that's well differentiated or poorly differentiated. But they are in the top layers of those cells, the skin. And it does, as I say, starts off as scaly. If you let it get bigger and bigger and bigger, it not just becomes scaly, it becomes quite hardened, and that's when it can turn into squamous cell carcinoma. Like any cancer, the earlier we get it, the better. And we do have to take a certain margin around any cancer cell or lesion that we've got. So obviously the smaller we get it, the less scar you're going to have, and the easier it is for us to excise it as well. Another type of skin cancer is the basal cell carcinoma, and they're those little pink, ready pink ones that they're quite small. They look pearly. Med school they used to always tell us it looks like the rat's tooth also. So quite often I'll say to the patient, oh yeah, you can see the little rat's tooth, the little dip in the middle. When we're doing the skin check, don't be surprised if we suddenly get an alcohol swab and wipe it over it, because it'll blush a nice pink if it is the basal cell carcinoma when we're trying to decide what we think it is. And in that case, that's at the lower level of the skin. It's that basal layer of cells that have turned cancerous. Not that we want skin cancer, but if you're going to get one, that's the one to get. It tends to be very slow growing, hence why we see it in older people, and on those really sun-exposed areas, the ears, the nose. And it tends not to metastasize. Not saying it can't, but it tends not to. Then, of course, there's the one everyone talks about, melanoma. And it's the one everyone seems to think is the only one that matters. Melanomas can be varying from really small, light brown, to a really deep brown, dark blue, with light brown sort of pattern around it. They're so variable. That's obviously the one that does metastasize, and that's the one that everyone sort of thinks it's deadly, which it is. That one we tend to see a bit more in younger people as well. So certainly, I've got a young gentleman, he came to see us, and he had, this ugly lesion on his calf, and it was probably about that big, but it had these 2 dollops of deep blue nodules and then brown around it. And so that was quite an invasive melanoma. So the deeper the blue and the deeper the colour, it can be the thicker the lesion is. Look, everyone talks about melanoma. That's the one that we always sort of hear about. That's the one that is on the media all the time. But the most common ones that we see and the one that actually kills more people, is squamous cell carcinoma. And that's because there's so vastly more of them than the melanoma. And all of them come through sun damage. But squamous cell is sort of especially in Queensland, central and North Queensland, yeah, the cane farmer has been out on the farm all these years and spent this whole time, or, you know, her time doing everything that they are. And yeah, so squamous cell is the most common, basal cell the next, and then melanoma, but melanoma is the most deadly. It's just that there's far less numbers.